Good evening, everybody, and welcome to this evening's Twilight Online Prescribing Pre-Exposure Prophylaxis for HIV in General Practice Part 1. We are joined tonight by our presenters, Dr. Brad Mackay and Dr. Nathan Ryder. Before we jump in, I would just like to make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. So I'd just like to introduce our presenters for this evening. So Dr. Brad Mackay is a general practitioner at East Sydney Doctors in Darlinghurst and is an HIV S100 prescriber. He's also the host of the Embarrassing Bodies Down Under television show and a TV presenter and medical advisor for the Today Show and Today Extra on Channel 9 and host of HIV in podcast. Dr. Nathan Ryder is a sexual health physician with 15 years of experience in HIV management in urban and rural Australia. He's the clinical director of sexual health for the Hunter New England Local Health District and the HIV support program coordinator for the Hunter New England Local Health District, and also a conjoint senior lecturer at the Kirby Institute, UNSW, and the University of Newcastle. So thank you, Brad and Nathan, for joining us this evening. I will hand over to Brad now to take us through the learning outcomes for this evening and then carry on with the rest of the presentation. So welcome, Brad.
Cool, thank you very much. Hi guys. We've got about over 110 people tuning in. Some people are just tuning in at the moment. So welcome to everybody. I hope you've all got your cup of tea handy as we're going to be going through a bit of prep tonight. So yeah, by the end of the online QI and CPD activity, you should be able to discuss the recent sort of PBS guidelines that are coming through and what the pharmaceutical benefits scheme or the advisory committee has come up with. You'll be able to list steps to prescribe PrEP to a patient, and this is one of the biggest things. We want you to be pretty confident when patients are coming in and asking for PrEP. And we're wanting to tell you where to go if you're needing a little bit of help as well. So we'll sort of go and talk about what is PrEP. So pre-exposure prophylaxis is what we're talking about tonight. So this is taking one pill a day to prevent people from getting HIV. So we will often say take one pill a day when you're brushing your teeth, and that's a way, rather than trying to fiddle around for a condom in the dark, it's a little bit easier for many people to do, and people will know that they're safe. So we're talking about two different medications that's in PrEP. So one of them is tenofovir disoproxil, if I'm saying that right. Nathan will probably correct me in a minute. And the other one is emtricitabine. And these are two different drugs that work together to stop HIV replicating and being able to get a hold and create a new infection in a new person. So some of the product names that we'll be talking about as well is Truvada. That's probably the most common. There's been lots of publicity around talking about PrEP or Truvada. Other people will be talking about like Tenvir as another name for it, or tenofovir, disoproxil, emtricitabine, myelin. Yeah, you don't need to know all of that, but mainly Truvada is probably the easiest way to go at this point of time. Yeah, so I'm interested to know how many people have been asked for PrEP already.
And let's just share that up on the screen so we can see those results for everybody.
Cool. So we've got 31% of us are yes, and we've got 69% of us are no. So yeah, it's still pretty early days as far as PrEP's concerned. So I've been working in Darlinghurst for about 4 years now. I feel like a bit of a baby when it comes to HIV medicine, even though I've been an HIV S100 prescriber for a while. But yeah, it's something that you'll be asked a little bit more, and we're finding that patients are very intelligent. They're all going online and they're finding out often more about it than what we do sometimes. So we'll go to the next slide here. So why are we using PrEP? We've found that there's been still a number of new cases over time of new HIV cases around Australia. So over the past few years, it's sort of traditionally plateaued at about over 1,000 new cases, but what we're trying to do is drop that down. And so our aim is by 2020. This is an aim that's used all around the world. This is an international aim to virtually eliminate HIV transmission by 2020. So we're finding that PrEP is already being really powerful. It's very effective, and we're starting to see a decline in new HIV cases, where it has been plateauing for quite a few years since we started bringing in PrEP. Even with people getting it online and ordering it in, we're seeing that decline in new cases. So this is really exciting. And since the 1st of April, April Fool's Day, wasn't anything to do with April Fools. This is really serious. PrEP has been available from community pharmacies everywhere. So if your local pharmacy doesn't have it, then yeah, please give them a call and ask them to stock it as well, because a lot of people will start to ask about it. And yeah, like even if you're putting up signs and saying that PrEP's available, then even patients in the waiting room would be able to sort of have a bit more confidence to talk to you about it. If people are getting it from the pharmacy, it's about 30 tablets in a bottle, and that's a cost under the PBS of $39.50 at this point of time. And if people are on a healthcare card, then they'll be paying $6.40 for a month's supply as well. And yeah, any doctor. So I became an S100 doctor 4 years ago, and yeah, did the training course, and I have a high load of HIV patients that I look after every day. But this is available for you. So everybody and anybody can prescribe PrEP if they're a GP. So this is really, really good. And we're trying to get PrEP into different communities that may have not been able to have had it before. We've had lots of trials around to enable us to get confidence and enable the government to get confidence with PrEP. So this is really exciting. And Nathan will go into a little bit more of these details. I might just hand everything over after this slide, I'll hand everything over. So yeah, so patients can use a prescription that's written by you to personally import the medication as well. So they can go into a pharmacy with it and get it over the counter, or else they can go online, scan in the prescription that you've written for them, and they can get it from different websites around the net. So one of the websites is PrEP Access Now, so you can Google that and find that. There's another one that is called AIDS Drugs Online, with little hyphens between AIDS, drugs, and online. So there are options, and for some people they might find that it's cheaper to get PrEP online. They may not be able to get access to a pharmacy easily, but they might be able to have something sent through to them in the post. There are a lot of people who will be coming in who aren't on Medicare, and so they won't be able to get PBS funding for it, but they still can go online and get it imported to them. And yeah, some people just don't want to have it on their record. They might want a personal choice of ordering in PrEP, or they might not want the government to pay for it for some particular reason, some ethical reason. But yeah, we're trying to make it as available as we can. So it's certainly an option if people are fitting into those categories, for them to be able to order it online and have it come to them in the post. So I'll hand over to Nathan now to talk a little bit more about prescribing PrEP.
Okay, thanks, Brad. So yeah, so I'm going to get into the details, I guess, about how we go about prescribing PrEP. And on the screen now is an example of a prescription, which I'm sure you've all seen plenty of. And the reason we put that up is just to show you that it really is a standard streamlined authority script that we're using here. So the end result is totally straightforward, something you're doing all the time. It's just a matter of getting the hang of the initial assessment and the ongoing monitoring that's associated with this prescription. So if we go on to the next slide. So what we're going to be really following along is the tool that was attached to the handouts for this talk. That's the Decision Making in PrEP New South Wales version. And really it's a pretty simple guide. It's 2 pages, and it really tells you all you need to know. And so if you have that in front of you, that'll make the rest of the night a lot easier to follow. Great. So if you want to move on to the next slide.
Yeah, and just for everybody, if you look in your control panel under your handouts and click the drop-down menu, you'll be able to find that PDF that Nathan is talking about for you.
So just to take a high-level view of this page at the moment, so we want to start on the page that's got the arrows across the top with 1, 2, 3, 4, and 5. That's the side we want to start with. And it's essentially what it's going to step us through is assessing the eligibility, which is really split up into 2 sections. So behavioural eligibility, and that will guide you as to when you should offer or consider using PrEP. Then clinical eligibility, which is about their medical contraindications, really. The other testing that we're going to do, then how to prescribe it, and then all the ongoing monitoring and education we need to provide. And on the back page, there's some details around it. So if we go on to the next slide, and we'll start to get into the details. So the first thing, obviously, is to think about when we want to offer PrEP or consider PrEP, and it's probably going to be a bit split there. So some of your patients are going to come in asking for it, and some of them you're going to detect the risk there, and either strongly recommend it or suggest they might consider it. And in terms of determining the risk, I think that really the best way to look at it is it's made up of 2 things, really. So it's made up of what broad group that person fits into in terms of their risk. And then secondly, the individual behaviours that person is having, and then put those 2 together, that's what gives you the individual level of risk. So if you move on to the next slide. So these are the sort of questions that we want to think about asking when we're gauging someone's risk. So I think the best way to think about this is, let's take an example. So by far and away, the most common example I see is a man who has male partners coming in asking, well, should I be on PrEP? I've heard all about it. What do you think? And so in that group, so immediately we've got a man with male partners. So that's MSM is a risk group that listed on the back of the slide, back of that guideline, and you can step through the questions. But essentially what we really want to know in that scenario is their partners. So are their partners known to be HIV positive and not taking effective treatment? Or are they partners of unknown status? Are they partners regular or casual? Are they having anal sex, and are they using condoms? And ultimately in that scenario, any unprotected anal intercourse with a person whose HIV status they're not certain about would meet the criteria for PrEP. But for the other groups, it might be slightly different. So for example, heterosexual people, it's mainly around HIV positive partners that aren't on treatment or partners from high prevalence countries. And the back really steps you through each of those groups. So just to note, in the next webinar in this series, there's going to be a bit more detail about how you go about doing this risk assessment in more detail. And obviously those skills have, a lot of benefit in other areas of medicine as well. It's not, taking a good sexual history is not just about PrEP. So if we move on to the next slide, it's just got a bit of a screenshot of that first section. So essentially we're working out if they're in the medium to high risk categories. And if they are, then we progress on to step 2. But if they're not, so if they're not risky enough that we think they warrant using PrEP, then that doesn't mean we do nothing. Of course, there are other methods of reducing people's risk. The main one obviously being condoms, and there's an opportunity to really think about that. So if we go on to the next slide. And so this is really a plug for the STI testing tool that New South Wales Health put out. So this is a really good step-by-step guide as to how to have that conversation about sexual risk, and then leading on, obviously, to any testing and interventions you might do around that. Okay, so once we've established that our person is at medium or high risk, and we've decided that PrEP probably is right for them, the next stage we need to do is a clinical assessment to see if, from a medical perspective, that they do qualify for PrEP. And really, there's a couple of key things here, and really, from my perspective, the two key things are, one, that they are definitely not HIV infected already. Because if someone is HIV infected and we put them on PrEP, we do run some risks of inducing resistance. And we define negative as a negative test within 7 days. So that can either be you've already done a test within 7 days, or you do a test today, but you tell them not to take the tablets until they've got the result from you. And the second thing is around renal function. So really the main sort of adverse effect of tenofovir, which is the key ingredient, is a potential impact on renal function. So we really want to know they've got a normal renal function to start with, and they don't have any highly nephrotoxic medications that they're taking, or obviously any other renal diseases that are going to impact on their renal function. So then if we move on to the next slide, so that again just shows you the flow chart out of step 2 of the handout, and just steps you through what you need to know. So the main things I said, no HIV, EGFR greater than 60, so no chronic renal disease, and no nephrotoxic medications. So the middle bit there is probably just worth touching briefly on. So if someone's HIV negative, but you're worried about a recent exposure within 72 hours, so that's where traditionally you would use PEP, which is post-exposure or after the case exposure. So it's now recommended that if they're probably going to be at ongoing risk, we may as well just start PrEP straight away. If you're in doubt, or if it's a one-off isolated event, let's say an occupational exposure, then ring the PEP hotline and get some advice around it. HIV positive is completely contraindicated. There's no situation which you'll prescribe PrEP for a HIV positive person. So if we go on to the next slide. So these are the sort of tests that we're going to need to do to assess that clinical risk. So we need a HIV test, so just standard HIV test. We need to assess their hepatitis B status, and that's because tenofovir is also active against hepatitis B. And if someone has chronic hepatitis B, we can still prescribe PrEP, but we've got to be careful because we don't want them to stop and get a flare of Hep B. And then, of course, just doing standard EUCs to assess their renal function. And you can see, highlighted down there below is a negative test within 7 days. I think this is probably going to come up again and again throughout tonight because that really is the critical thing in terms of risk. So if we go on to the next slide. So once we've determined that they're clinically eligible, now we've got to move on to the additional testing that's recommended. And so the main thing there is around, based on their risk assessment that you performed initially, you're going to have a degree of understanding of their risk from sexual and injecting behaviours. And we would recommend testing according to the Australian STI guidelines, which is going to be mainly around the other bloodborne viruses, especially hepatitis C, the STIs, and in a female patient, a pregnancy test. Okay, so this is the link to the STI guidelines that I just referred to. And if you, hopefully you've all seen this, it's a very well utilised guideline. It gets good reviews from GPs. If you click on the populations and situations and choose your group, so the example I gave was a gay man, so we'd click on the metaprotective men tab there. There are tabs for all different risk groups, and that guides you through what sort of tests you need to do. So if we move on again, and now we get to the bit which actually probably generates the majority of my questions, is the nitty-gritty of providing the prescription. So I'm sure all of you are using electronic systems now, so you just need to search for tenofovir emtricitabine. As Brad pointed out at the start, there are 3 brand names in Australia. They're all equivalent. There are occasionally I get questions because they are subtly different. Some of the salts and the exact milligrams are subtly different, but the active ingredients are exactly the same, and there's no way of distinguishing. Truvada's the originator product, so that's probably why most people have heard of that the most. So if you search your practice software, tenofovir, you'll come up with it. In terms of the streamline codes, so for PrEP, it's 7580. Just be aware that there are streamline codes for HIV treatment. You need to choose the streamline code for PrEP.
And with
the prescription will be.
Yeah, if you're looking at it, you'll see that the tenofovir for PrEP is 30 tablets and then there's 2 repeats. The one that's for HIV has, I think it's 60 tablets and then 5 repeats. So that's more for HIV treatment. But yeah, if you're looking at PrEP, it's going to be the 30 and then the 2 repeats. So it's, yeah, another sort of safety feature that you're not ticking the wrong box.
Yeah, and I mean, I think it is pretty clear. I think you'll see the first time you do it that it's not difficult to choose the right one. Okay, so if we move on to the next question. So I've generated the prescription now, and we're giving it to the patient. They're about to wander off. So what do we need to tell them? So really, there's a few critical things that they have to know before they walk out. So the first thing is that it's obviously going to take a while for them to get protected. Walking out with the prescription doesn't immediately protect them. They need to take the tablets consistently for 7 days to get high enough levels for protection. The levels take a lot longer to reach protective levels in the vagina. If they take it consistently for 7 days, then that's enough. But particularly for vagina, it does rely on them taking it every day of that 7 days. If they decide they want to stop, and we definitely recommend against stopping and starting, but obviously they may want to stop, then they need to continue it for 28 days following their most recent sexual exposure, or the most recent unprotected sexual exposure. We want to discuss side effects. So the main one I warn patients about initially is nausea. Most people will get some degree of nausea within the first couple of weeks. It almost always settles down within the first 4 weeks, but occasionally persists. If they take it with food, they get a lot less nausea, and just experimenting with different times of day can help as well. It's important that we don't give people the impression that PrEP will protect against everything. We definitely recommend condom use to protect against STIs. But in practice, many people who are coming in requesting PrEP or who meet the guidelines for requiring PrEP are having unprotected sex. And so it's just important to, when you have that conversation, it's not a lecture, it's a discussion around when they might choose to use condoms, and encourage them to think about using them as much as possible for them. And finally, it's important that they know that when they turn up to the pharmacy, it probably won't be in stock. Some of the larger pharmacies may start to stock it, but many will need to order it in. In my experience, even in rural areas, they will generally get it in within 24 to 48 hours. So after they've started taking it, so what sort of follow-up will they need? So the key first point of follow-up is at 30 days after that first bottle. And at that point, we want to get them back and we want to test them again for HIV. And that's because we need to be 100% certain they didn't have HIV before they started taking it. So if they were in the window period at that initial negative test, there was obviously a chance that they had HIV. And don't forget, we've selected out a high-risk group here. So we want to do another HIV test at 1 month to make sure that they don't have HIV. That's a good point to talk about what side effects they're having, how they're going with adherence, and that sort of practical stuff. But that's all we really need to do at that point in time. Then at the first 90-day interval, we do all that again, but we also add in a repeat renal function test and STI testing. And then from then on, every 90 days, we do a HIV test, the STI tests, and in females, we do pregnancy testing if they might be pregnant. And we do the renal testing every 6 months. So every second prescription, they get renal testing, basically. And that can continue indefinitely. There's no maximum period of time someone can be on PrEP at the moment. So every script goes for 90 days, and every 90 days, they get that battery of tests. One thing to think about is, so we're recommending testing for Hep B and Hep C, sort of at baseline and as required. So to think about if they're negative for Hep B, vaccinating for everyone on PrEP, and for men who have sex with men, thinking about hepatitis A vaccination as well, as hepatitis A can be sexually transmitted, and there have been an increase in cases in Sydney and Melbourne recently. So if we move on to the next slide, so obviously in addition to all those assessments and tests, we're going to want to provide some education. And really, I think the key one here is about adherence. So in the PrEP studies, PrEP was highly effective, but it did fail in around 1 in 10 people. And that was basically because they weren't taking it. So I'm sure we all know from all areas of medicine, tablets don't work unless you take them. PrEP's no exception to that. It's pretty forgiving though. So if someone does come in saying they're missing some, you can be encouraging. We know it works if they take 4 a week on average. We don't recommend people aim for 4 a week because that's pretty hard to do, and it doesn't give you any leeway. So we recommend daily, but 4 a week will protect you. For the females on PrEP are very rare, but if you do have a female on PrEP, and I do have one myself, it's more important that they maintain 100% adherence because of that issue that the drug levels in the cervical and vaginal tissue really aren't as high as the rectal tissue. So obviously using your chronic disease management skills that you have, just draw on those to really talk about how they might improve their adherence and how to manage side effects. So the second part of education really is around ongoing risk reduction. So I guess, it's the same conversation that I touched on a few minutes ago around, encouraging ongoing condom use. So not necessarily every single prescription, but, on a regular basis, particularly if it's prompted by the diagnosis of an STI, or, patient questions about STIs, discussing where condoms might fit into the mix for that person. And I guess from my experience, some people don't use condoms at all. Some people use condoms almost all the time and treat PrEP as a backup option type thing. But for the majority of the people that I've had, they'll describe to me that they make an individual assessment. So they might have a couple of people that they have unprotected sex with, but if they had sex with someone they really didn't know at all, they'd be more likely to use a condom in that scenario. And I guess I'll focus my research around that sort of idea. So it's probably also good to talk about communicating to their partners around PrEP. And I think you'll find this is already happening. So on many of the social sites, PrEP status has become quite clear. But just having that open discussion with people about how they communicate about their PrEP use and others' PrEP use. So if we move on to the next slide. So we've discussed really all of the required things. So all of the things that really should be part of standard practice. Okay, so now we're coming on to some of the things that really aren't standard practice, but you probably should have some understanding of. And this might be a situation where sometimes you might want to get special advice. So although the main risk we're concerned about is renal, tenofovir also does have an impact on the bone cells, and it has been associated with some degree of osteopenia. It's relatively minimal. It's certainly not been shown to be clinically significant in terms of fracture risk, and it is reversible on stopping PrEP. But there is that risk there. So in people who have other risk factors and underlying risks for osteoporosis for other reasons, you might want to think about vitamin D levels, and you may even want to think about measuring bone mineral density. Now remember, this, as for most other indications, is not listed on the Medicare schedule, so they would be paying for it. But of course, similar to I'm sure you're already doing, you may want to think about doing that in some high-risk people. And the second thing is, because, as I've said already several times, we certainly do not want to be prescribing PrEP to someone with HIV infection. If a person develops symptoms of seroconversion, then you want to get immediate specialist advice around that. I would caution against just testing and seeing how it goes, because we do want to stop as soon as possible if someone is HIV infected, but we don't want to stop a high-risk person unnecessarily who then seroconverts or contracts HIV a week after you stop them. So if you think they might have early HIV infection, definitely call for special advice immediately. And I think in all areas of New South Wales Health, you will be able to get specialist advice immediately for that reason. So if you go on to the next slide, so this really steps through in a bit broader sense when you might think about getting additional advice. I guess really the one there that's missed off at the bottom is you can always ask for specialist advice. So if you're ever uncertain, just ask. But I would particularly encourage you to think about asking if someone has chronic hepatitis B, if they're under the age of 18, and then remember that people under the age of 18 are not covered by the PBS listing, and it would be off license use as the TGA listing is for over 18. Anyone with an EGFR less than 60, so that's really a contraindication on the decision-making flowchart. Occasionally, we might put someone on it if they're extremely high risk, but I think that would really be a specialist assessment. That might be a phone call. I'm not saying that needs to be referred, but we need to weigh up the pros and cons there. Pregnancy is a similar situation. So, you know, PrEP is a perfectly reasonable thing to use in pregnancy, but you would definitely want to weigh up the risks and benefits. And that issue that we discussed right back at the start, if they had a recent high-risk exposure within 72 hours, to get some advice around the PET versus PrEP decision. And then, as we just discussed, the potential early HIV. So if you go on to the next slide. So how can you get this information? So I've got the number there for the New South Wales Sexual Health Info link. So that's staffed Monday to Friday and can connect you immediately to information. They will provide you with simple information straight away. But if you need to speak to a local specialist, they'll connect you to your local sexual health clinic. They also provide support to the general public, so you can give that number to your patients and their partners to call for advice around PrEP. So I think it's over to you, Brad.
Sure, no worries. So yeah, so just looking at some clinical resources that can help you. So if you've got any questions, as Nathan was saying, please give us a call. And yeah, getting advice over the phone is often quick and easy and specific to the case that you're looking at. But yeah, there's a number of, I think we're going to link to all of, there will be links to all of those that you'll be able to get afterwards as well. But yeah, you can just go to the New South Wales Ending HIV website to get a little bit more information after this session if you so desire. And we'll just go to the next slide. And yeah, so just talking a little bit about this. So how effective is PrEP? We've had a number of different trials around the world, including in New South Wales. I think New South Wales itself was one of the biggest trials that the world has seen with PrEP. And we've got, yeah, lots of effective trials, mainly concentrating on men who have sex with men. But yeah, we've also looked at the ability for PrEP to work in heterosexual adults and also with people who inject drugs as well. And one of the problems with these studies is that transgender people haven't been well represented. And I've been to a number of conferences lately, and trans people are certainly on the agenda. We're starting to enlist them. We don't really see if it's going to work in a heterosexual adult, if it's going to work in somebody who's male or female. We can't see that it's going to be working any different in somebody who's transgender. But of course, we like to get that scientific proof as well. But yeah, I wouldn't be too worried about it. If there are any concerns or if they're on different medications, then of course, yeah, talk to your local sexual health clinic or call the hotline that Nathan mentioned as well. And just go to the next slide. Yeah, so this is just a reminder that for people that are taking PrEP, we're really recommending them to take it like correctly and consistently, and we don't talk about compliance anymore. We talk about adherence to their medication. So yeah, it's trying to sort of talk with patients, saying, yep, if you're going to be prescribing it, then yeah, put it near your toothbrush or put it near your toothpaste or put it near something that you do every morning, just like we'd talk with any other pill that we prescribe. And yeah, we don't really know if people are taking less than daily PrEP, if that's going to be protective. There is some information to show that it's likely is. There's a lot of people talking out of San Francisco at the moment, saying that if people are taking 4 or more tablets per week, that it should be okay. But we're really conservative in Australia still. So if they're missing the odd tablet every now and again, it's not the end of the world. There will be a bit of a buffer, But we do sort of really want to drum it into people to take it every day and get into that routine of taking that medication every day. And I think I'm passing back to Nathan to talk a little bit about the safety regarding PrEP.
Yeah, thanks, Brad. Yeah, I mean, just looking at those other slides, like it is incredibly how efficacious PrEP has been. And I'm sure, as you know, Brad, that there's really only been 3 known cases where someone taking PrEP contracted HIV globally out of many tens of thousands of people. So it's undoubtedly extremely efficacious. But the other side of it, of course, is the safety. And, you know, patients obviously want to know details about this. So I guess with the drug we're talking about, we've had many years experience with it in HIV positive people. And then we've got, you know, several years experience from the PrEP studies. Most of those studies haven't had an awfully long period of follow-up, but as you can see in the slide, some of them went as far as 4 years. So most people did get some degree of mild nausea, as I said already. But, you know, generally, the overwhelming majority of people haven't had those sort of ongoing annoying side effects. They generally will subside. I've had just a handful of people stop due to those annoying little side effects that they get. So if you go on to the next slide, so really in terms of the key safety issues, so as I've mentioned already before, so renal function is really our major worry. So PrEP will likely cause a small initial drop in renal function, but it doesn't tend to worsen over time. When they stop PrEP, it does return to normal as well. So from the studies, it certainly does not look like that's an issue, but it was more likely to occur if you had people over the age of 40 and, not in the slide, but also under the age of 20 as well, and people with pre-existing renal dysfunction, but not to the level of chronic renal disease, so between 60 and 90 eGFR. So if you've got an older person or someone with a reduced eGFR but still greater than 60, that's the group you might want to think a bit more. Now, I still recommend you prescribe, but that's the group where you're definitely going to want to, you know, assess their renal risk in general, like you would normally, and just make sure that they are having those regular renal follow-ups. Make sure you keep updating their medication history to pick up any nephrotoxic medications. So the next thing, as we discussed already as well, is around the bone mineral density. So a small number of people, they did notice a decrease in bone mineral density, not to the osteoporotic level, but osteopenic. And that was reversible when they stopped it. And even in HIV-infected people that generally tend to have a lot more of these side effects for reasons we don't fully understand yet, this decrease in bone mineral density hasn't been associated with fracture risk. So it doesn't seem to be clinically significant. But I guess with both those two things, the impact on the kidney and the impact on the bone, for an individual, that might be important. And I guess that's why we've got the category of consider for the medium risk. So if someone's at medium risk of HIV, and they're really worried about those sorts of side effects, well, I mean, maybe that's a reason to encourage them to think about increasing their condom use rather than PrEP. But it's clearly going to be an individual discussion and decision. So the last thing, and probably one of the things that people worry about the most, but really hasn't panned out, is introducing resistance. So if someone contracts HIV while they're taking PrEP, because it's not a fully suppressive HIV regimen, it could potentially induce resistance. That really hasn't happened. So there's been several cases of people contracting PrEP, well, in numerous cases really, due to poor adherence. And in those cases, the overwhelming bulk of people did not develop any resistance whatsoever. And in the small number of cases where they did, it really wasn't a significant degree of resistance, so minor mutations that cause minimal impact on their future treatment response. So whilst that's something we certainly need to keep an eye on, it's not at the moment, it's definitely not a reason to be cautious about PrEP prescriptions, so long as we're following these guidelines that we've stepped out.
In relation to that, Nathan, you mentioned that there's been about 3 recorded cases around the world where people have become HIV positive while on PrEP. My understanding is that it was just a freaky virus that was resistant to both of the medications that was in the PrEP. Is that your understanding?
Yep. So 2 of the 3 were resistant viruses. So if the virus is resistant to the drugs that we're using, well, clearly it's not going to work. But the good thing is that we know that in Australia and in New South Wales, we've got particularly good data. We know that those resistant strains just really aren't circulating in the community at any significant level at all. So whilst it's not impossible, and I certainly don't say to people PrEP is 100%. In practice, it's extremely unlikely that it's going to fail if they are taking it. And there's the one case where they weren't resistant, but I don't think we fully understand that one. But that's one case out of many tens of thousands of people with, I hesitate to guess how many episodes of unprotected sex there would have been, but it's obviously an extremely rare event.
Yeah, and we've just got a couple of questions coming through as well, and I'd encourage everybody, if you do have questions, send them through. One of them is, do we need to do a DEXA scan before initiating PrEP? What are your thoughts on that, Nathan?
No, definitely not. So I would definitely restrict DEXA scanning to people who have pre-existing other conditions that put them at risk of osteoporosis. Or potentially they've got osteoporosis, you want to know to what level, where you're making a risk decision between, is PrEP right for them or is the risk to their bones too great? So we've had one person that we did start, he had known osteoporosis. We did start him on PrEP because his risk of HIV was extremely high. And of course, if he got HIV, well, he's going to have that risk of osteoporosis anyway. So we decided in that circumstance, that his DEXA was okay, and that we would prescribe. But that's really the only time I've ever done a DEXA myself, because the majority of people I'm starting PrEP in are young, they're mainly male, their risk of osteoporosis is extremely low, so it's not indicated. I guess a way to assess that would be the FRAX score, so I'm sure you're all familiar with using the FRAX score. So if someone's got a higher FRAX score, then yeah, you could think about doing a DEXA scan.
And I always encourage my patients to go to the gym and buff up their bones from doing weight-bearing exercise. So that's one of my motivations for getting them exercising. There's also another question here saying, can you have bisphosphonates as well if you're on PrEP?
Yeah, so I guess that's what I'm getting at. That you have to make an assessment of that person's risk of osteoporosis and risk of contracting HIV, and yeah, it's not absolutely contraindicated, but you factor that into your decision. These are situations where you might want to ring up and discuss with your local specialist as to what they think the risk might be.
Yeah. Okay, well, we'll move on. We'll come back to a few questions in a minute. But yeah, talking about the EPIC New South Wales trial, yeah, this was, well, we're sort of in the final stages of it at the moment, but this was led by the Kirby Institute and funded by the New South Wales government. They were funding all the tablets for everybody. And yeah, this was as far as I'm aware, this is the largest scale rollout of PrEP around the world, targeting people at high risk. So there were over 9,000 people, and I think we've stopped enrolling now, and we're just tailing people off. But this was looking at real life and testing people regularly and seeing if PrEP is actually working for these people that were at high risk of HIV. And yeah, so far around Australia, and particularly in New South Wales, we haven't had any new HIV diagnoses in the people who have been in the trial who have taken PrEP as we've instructed them. So it's always a miracle when our patients take medications as instructed, but this has been a really, really good thing. So we'll move on to the next slide. And I think Nathan?
Yep. So yeah, so the EPIC study has been incredibly successful at getting a lot of people on PrEP in New South Wales, and I guess we're now in the phase of rolling that over to PBS prescriptions. But during that time, it was really phenomenal to see the decrease in HIV diagnosis in New South Wales. So you can see the numbers up there, but essentially just huge drops in new HIV diagnosis, especially in men-infected men. That's the key risk group. It is important to recognise that at the same time as the PrEP rollout was happening, we continued to dramatically increase the number of people being tested for HIV and getting people that are HIV infected on treatment virtually immediately. As I'm sure you all know, if you are HIV infected and start effective treatment, your risk of transmission drops to zero quite quickly. And so between those two things, so high risk negative men being on PrEP and HIV positive people being on effective treatment, probably the combination of those two things is what's led to this incredible drop. But unfortunately, it wasn't evenly distributed. So if you look on the next slide, it really highlights where we need to put some more work into it. So unfortunately, if we drill into the numbers, those large drops were mainly in Australian-born men of sex with men. So other risk groups, so including young MSM, including MSM who live outside of the traditional gay suburbs of Sydney that have access to incredibly skilled GPs like Brad. The MSM that are overseas born, it may not necessarily reach all of these resources and prevention strategies as easily, and not on the slide, but importantly, heterosexual people. So those groups haven't experienced such huge declines in HIV and potentially really haven't taken up PrEP to the same extent. And I guess from my perspective, particularly coming from a rural area where all of my gay men live outside of traditional gay suburbs, I think this is where GPs can really come in and make a big difference. So gay men that might be out there and they've heard of this but don't really know where to go and go to their GP. So just having confidence that the GP will know how to pull this flowchart up and follow it can make a difference for these groups that are currently being left behind. So if we go on to the next slide. So one of the things that comes up a lot is, well, if everybody's taking PrEP and not using condoms, won't we just see more STIs? And we haven't really seen that as yet. So the rate of STIs is high. So the rate of STIs that we see when we enroll someone in PrEP or start someone on PrEP is really quite high, but that's because we've selected a really high risk group to start with. And then we follow them over time. We really didn't see an increase in that, and we're really not seeing much of an increase in the notifications statewide. We are seeing an increasing trend, but that's been going on for a very long time. There's no real signs that this take-up of PrEP has led to an explosion of STIs. Now, why that's happening, well, I guess we'll see over the longer term. But what we think is happening is what we hoped would happen at the start, and that's that we're testing a very high-risk group very frequently and treating them. And so therefore they're not transmitting that to other people and not suffering the consequences themselves, of course. So whilst we've probably seen some decrease in condom use, that's been covered for, I guess, by that increased amount of testing and treatment. So we go on to the next slide. So this just really shows in numbers, I guess, what I was just saying there. So you can see the numbers that, high. There's no doubt that's a high rate, but they've been stable, and that's really what matters. I think, that covers it for STIs.
Okay. So I'll continue on here. So so just a reminder that by 2020 we're trying to really get on top of this around Australia and hopefully have negligible new cases of HIV around. So there's a whole variety of different strategies that we're using. One of them is PrEP, but there's a whole range of other things. And I'm just having a look and seeing if there's other questions. There is a question that's here saying, can we use PrEP for a doctor who has a needle stick injury? You'd probably be asking for PEP in that regard and going through the normal category for that. And what else? I think we've Can we start PrEP if the patient has an EGFR less than 60? I think Nathan spoke about that previously. It's sort of monitoring them and considering seeing a renal physician and closely monitoring their EGFR over time. And we'll continue on. We'll come back to a few questions if we have time at the end. We'll move on to a clinical vignette. So this is Dang, a 30-year-old male. So he was born in Thailand. He's been living in Australia for about 3 years. So he's now a student, and he travels back home 2 or 3 times a year. You've been seeing him for a couple of years, and he just comes in with coughs and colds. He has sex with other men, and the most recent presentation, he has had a widespread maculopapular rash, and he's been referred to the infectious diseases team at the local hospital. So no sexually transmitted infection or bloodborne virus tests have been undertaken. So the infectious diseases team felt that the rash looked like secondary syphilis. This was confirmed with a positive TPHA test and an RPR of 32, showing that syphilis is active. He also took an HIV test, and that was positive for HIV-1. Additionally, it showed that the CD4 count, so the lymphocytes, was really, really low at 17, and that his HIV viral load was at 97 or 98,000 copies in every ml of blood. So what is the HIV data telling us in New South Wales? So we'll discuss the case as we're going, but yeah, what's happening here? So, so this is a number of New South Wales residents notified with newly diagnosed HIV infection between 2011 and 2017, and we see that back in 2011 it was between about 300 to 400 new cases of HIV. As I said earlier on, around all of Australia it was about over 1,000 cases for quite a few years, and we're starting to see that drop. So we started bringing in PrEP about sort of 2014, 2015, people were starting to use it, and it sort of started to pick up speed over the last couple of years. And we'll go on to the next slide as well. Nathan, if you wanted to continue with this.
Yeah, so if you pull apart that drop, so as I think we've sort of touched on before, that the predominant drop is in Australian-born men of sex with men, so that there's been a 48% drop there. And really importantly, early stage infections have dramatically dropped. And so, of course, you remember if someone's got late HIV they contracted 10 years ago, there's nothing we can do to prevent that case occurring. But we can prevent early infections. And that 63% drop in there really shows, how this is working. But unfortunately, if you look at overseas-born MSM, that's increased by 29%, and early stage infections have increased by even more than that. And so these are infections really that should have been averted through these prevention methods, but unfortunately weren't. And a group again that's not on there is heterosexuals, and particularly heterosexuals that have travelled to areas where there's more HIV infection. That's still continuing to increase, and so we've really got to look at how we can get prevention strategies out to that group. And New South Wales Health doing some work to better understand what's going on in this area at the moment.
So yeah, so with this is some of the flyers that are going on, some of the posters that are getting out into the public, and we're trying to focus on different groups. So it sort of seems like men who have sex with men are low-lying fruit. These are the people that we've really been focusing on for a while, but now we're sort of trying to broaden that web. We're sort of, as Nathan was saying, we're sort of seeing that people who are heterosexual are sort of increasing their percentage of new HIV cases. So with these 2 posters that are up at the moment, have you seen the posters? Yes or no? Okay, so most people haven't seen it. 83% haven't seen the posters. So that's really disappointing. We're not getting our messages out there. And this is one of the things. This sort of highlights the point with the case that I mentioned before with Dang. He's sort of like, doesn't often talk about things. He might see his GP about coughs and colds. And if we're not sort of thinking HIV, if we're not having those sexual health discussions, if we're not sort of like wondering about HIV as a diagnosis, then he can have HIV for a number of years and then present really, really late. And this is what we've found in the case. When his CD4 count was really, really low, it was showing that his immune system had been whittled away over time. So yeah, so we're needing your help to really get those messages out there, and hopefully you'll see a few more posters when they're put up around. So yeah, so as we're saying, like 1 in 5 people with HIV are heterosexual. So this is really important to keep in mind. Holiday sex, or sex holidays as I usually call them. Yeah, sort of thinking about people, and I always sort of think, do I do a sexual health check if somebody's coming back from overseas? So really important to keep that in mind when you're seeing your patients. So we'll go on to the next slide. And yeah, so cool. So yeah, so as his primary healthcare provider, was there anything in his history that would make you think of offering an HIV test? So yeah, so with that in mind, it would really be having sex with men and traveling overseas to Thailand as well. And yeah, so we're just sort of like careful to keep that in mind. So and yeah, think outside the box as well. Ask people and ask if it's suitable to do an HIV test with them. We're just not wanting to miss that, and also take those opportunities to ask people about PrEP too. So we'll go to the next slide. And how are we going with HIV testing in New South Wales? So yeah, so in 2017, GPs made approximately 41% of the new HIV diagnoses in New South Wales. So this is all of you guys, not the hospitals, not the sexual health physicians, but yeah, 41% are in GPs, in GP clinics. Of these, 34% were diagnosed by GPs who weren't accredited to prescribe antiretroviral therapy. So this is garden variety GPs who haven't done specific training or aren't working in HIV clinics. So yeah, so it's just over a third of cases are being diagnosed by you. So increased testing leads to earlier diagnosis. So we're just wanting to make sure that that we're thinking about it. And what happens when you make a new HIV diagnosis? So 31% are yes and 69% are no. So yeah, so the majority is no. So it's not surprising if you're working in general practice and not specifically a sexual health clinic. But yeah, it's to keep that in mind to have a look and get some extra support if you're needing it. So help is certainly available. In the instance that you do make a new HIV diagnosis, then yeah, it's sort of keying your patient in to further support. And there's a variety of different programs around depending on which area you're in. And yeah, every person who's newly diagnosed with HIV infection has the right to other support services, and we try to provide that as much as possible. And Nathan,
so I think this is, yeah, so I am the HIV support person for my area, Hunter, New England. So I'll just briefly talk about how it works. It's really pretty simple, and I've had 100% positive feedback so far for me. So essentially what happens is when there's a positive HIV test, obviously the lab will tell you. They'll normally ring that sort of thing through. And then they inform New South Wales Health as is standard practice for a notifiable disease. They then notify the local health district's HIV support program officer, which is usually the sexual health specialist or an ID specialist, in a sort of a de-identified way. So we don't know the patient's name or anything. We just know your name and the person's sort of coded information, so we can make sure we're talking about the same person. And if you want to call, you can say no, but if you say yes, so I'd like a call, then they tell me when you want to be called, and I'll make an effort to call you at that time and just discuss what you need to deal with that case, really. So what I do is completely different every call. Some people have diagnosed a few cases before and are totally across it. Other people want a lot of information. So essentially we just talk through how you're going to manage initially and what the ongoing plan is. So the next slide's got the 5 key support services framework, I guess, that we use. And we sort of basically try and sort of use that as a framework to think about, okay, what do we need to do? So the first thing, obviously, is management and treatment of that person. The next thing is what sort of psychosocial support they might need. Thirdly, we look at, well, what about others that might be at risk? And so obviously, if they've got a partner, thinking about whether that partner needs PEP, if they've had recent risk. Letting previous partners know, part of contact tracing or partner notification, and then making links to the specialist and community services that person might need, and that, you know, what ones are going to obviously depend on the individual. So that we sort of step through that, and the extent to which we get on each one really depends. You know, sometimes it's all about how to give that diagnosis if it was unexpected. Other times, you know, we might get into a bit more of that sort of stuff. Some of it doesn't happen until they've seen a specialist for treatment. But, you know, we work it out individually what that person needs. I think it's back to you, Brad.
Yeah, sure. So so I always remember before I was working in HIV, I would always have a new diagnosis of HIV and panic. So it's always important when you get that reading back to know that you can call the number that's on the screen there, and ask to speak with somebody, and get a bit of a plan of attack before somebody comes in, and you need to deliver that information to them. So yeah, just making sure that you're up to date with all of the knowledge, and you know exactly what needs to be done, and it's important to find out what's available in your local area. So I think we're needing to close up now. So just a conclusion, PrEP is now available on the PBS after April the 1st. GPs, everybody who's listening will be the primary providers of PrEP in New South Wales. And that there are clinical tools and resources available to support GPs in prescribing PrEP, and we will have all of those links available. And just remember to keep it in mind. Don't forget about HIV, testing it at every opportunity, because you're not wanting people to present late and have problems with it. And make sure that if people are at risk, that you're talking about PrEP and making sure that that they're up to date and knowledgeable about it.
Fantastic. That actually brings us to the end of this evening's session. So up on your screen at the moment, we're just revisiting the learning outcomes that Brad took us through at the beginning. So we hope that you can now leave this session and have a bit of a better understanding of how you can prescribe PrEP in your practices. We will be running part 2 of this webinar, conducting sexual history, on the 7th of August. In the follow-up email that goes out after this webinar, there will be a link to the registration for that. So in saying that, I just want to thank everyone who joined tonight, and a big thank you to our presenters, Brad and Nathan, for joining us.